So as Kate said, my name is Joanne Law. I actually went through the social work program almost 20 years ago now, this program, and was a social worker with people with developmental disabilities for about 10 years after that. And then my interest in health took over, so I went back and I got my nursing degree, and I was lucky enough to land a position that kind of merged those interests, so developmental disability and nursing. So I'm one of 3 nurses that work in the WIN program. The WIN program is an outreach program that's part of the Wiseman Center outreach programs. So they are ties, and there's a psychiatric clinic there. There's Love Dane, which is works with families on connecting families. There's adaptations and modifications and crisis response. So there's a variety of programs, and we fall under that umbrella of programs. So we're called Wellness Inclusion Nursing, and what we do is consult with the individual and their team. So typically they're supported in a residential setting, so they have a residential agency, vocational agency, and we would connect with all those, the individual, their family, and all those people to work together. And our focus is on keeping people in the community wherever possible. So maximizing health and wellness and independence. So ensuring that people with developmental disabilities can achieve the best life possible. So we're a program that contracts with Dane County, and we only work with people who are in the supported living programs. We do work with a few people who live with their families, but that is the exception. So what do we do? So I think the reason that a WIN nurse might be needed in a team is because there is a lack of communication maybe, or understanding amongst the medical providers or the staff, or whoever it is, for the person with the disability. So I'm just going to go through kind of the places that we work with people and give you some examples of what our work would look like. So if somebody is in the hospital, say they have pneumonia and ended up in the hospital. So we would go to the hospital and help the medical staff, so the nurses and the providers, the doctors there, understand the person. And also help the communication between the individuals, the medical providers, and the support team. So help everybody understand what each other is saying. So the support team are the people who know the person best, and then the providers, the nurses, the medical providers, are often talking in jargon or medical language that is not necessarily accessible to people. So we try and put it into understandable terms. So that the hospital staff understand the person and their communication, and also what is normal, what they normally look like. So what is baseline for this person? Because there can be a lot of assumptions made that somebody coming in, so I work with a man who has cerebral palsy, who's in his 60s. He was in the hospital for urinary tract infection that got really bad, and an aspiration pneumonia, and he'd lost weight, and a lot of things kind of culminated together, and he was not doing well. And the doctor, who was, just an associate there, was immediately jumped to the conclusion that, okay, this is end of life for this person. They've got cerebral palsy, they're in their 60s, there's all these complicated health issues going on. Maybe we should think about hospice. And so I had actually called the family member and said that, and the family member had just freaked out, and oh my gosh, this is end of life. And so I was able to say, no, this person actually does have a pretty good quality of life, and he lives in his own apartment. He has staff coming in who support him. This is just a health crisis, and there's a lot of things going on here that we really, he's not ready to give up. You can actually talk to him and ask him, and he will be able to tell you that. And so the doctor in that situation actually turned around like that and became extremely helpful, and was a great advocate to get him into the best rehabilitation place for him. So it's just it's a lack of understanding. It's not a lack of willingness sometimes. We also, in working in hospitals, we advocate for safe discharges. That's such a huge issue. If people are discharged too early, they go home, they could get right back into the hospital again with a health crisis. So making sure that people are stable, eating, drinking, peeing, pooping, all those kind of things that have to be happening before they can go home. Also, whether the person could benefit from rehab, so going somewhere for PT, for physical therapy or occupational therapy or speech therapy, depending on what the issue is. Whether that needs to be done at a facility, like a rehabilitation, a place that does that. So if somebody goes to a nursing home, they can get very intensive rehab. A lot of people in our system who are older, though, have a great fear of nursing homes, that they've been institutionalized themselves in the past, and so helping them understand that this is not going to be forever. They're not going to keep you there. You just have to get some intensive therapy, and then you'll get stronger and be able to return home. Or whether that PT and OT could be done in the community. So figuring out, what is a good plan for this person. We also just go to people's medical appointments with them. So go to annual physicals or whatever appointment it is their, specialist appointments. So endocrine if somebody has diabetes, and so that we can help. Again, it's that crossing the bridge between providers and the individual and staff, so that we can help everybody understand what's going on and help them develop a plan for when they're home and what is that plan going to look like. So, for example, a lot of people have issues. An awful lot of people in our system have issues with constipation. It's just a crisis. I mean, for many different reasons. And if we can help people develop a plan for that, so that they're not ending up in the hospital with an impaction, or if we can prevent some of the effects, the ongoing effects of constipation, then if we put that plan in place so that people are actually having bowel movements every day. I know it's not a fun thing to talk about, but it's actually one of the things that we talk about, that we deal with probably more than anything else, because people are on medications that cause constipation. They're maybe not drinking enough fluids, their diet isn't ideal, so we can work on all of those things. What medications is the person on? Do they really need to be on them? Is there an alternative? Can the person drink more? Can we get their fluid intake to go up a bit? Can we include some fiber in the diet? And also look at medications that help with that. So having a real clear plan for staff to follow, and making sure that charting is done so that we know where people are at. With that is really an important thing that we can do. Another reason that we would go to appointments is to advocate that people are getting the screenings that they need. So if somebody has some behavioral dysregulation when they're at medical appointments, then the provider may decide that they are not going to look at the skin that we've come in about. They're just going to take it from the staff about what's happening, because sometimes they want the person out of there as quickly as possible. So, just advocating that, no, actually, we need to get this person up on the table. You need to look at the skin and what's going on so that we can get the right treatment for it. Sometimes, people decide that they don't need to have breast mammograms or whatever the screening is. Then we always advocate blood work, for example, making sure that people get the blood work so that their whatever it is optimized. We focus a lot on wellness as well, so making sure that people's vitamin D is where it needs to be, and those kind of things as well. We work in the home, so we work in the hospital. We go to appointments with people. We also work with people in the home, so we would go to the home and we might do a nursing assessment. So that assessment would be an individual assessment. So we would take somebody's blood pressure and do vitals on them and check if they have edema and check if their skin issues. But we're also looking at medications, so we're looking through their MAR, making sure that dosages are right or they're on the correct medications, they're being given correctly. But we're also assessing their environment as well. So looking at the staff, how much do the staff understand the person? Is their home, is it accessible enough? Do they have the right supports? So, and doing trainings as well. We do a lot of trainings for staff in the home. So they would just collect their staff team together, and we can do individualized trainings for people on whatever their need is, whether that be skin or whatever that is, diabetes. So also with recreation or exercise, we can help make sure that people are getting to where they need to be. If they're wanting to exercise, figuring that out, like what would be the best thing for this person to start exercising, how would that look? So making sure also, so if somebody has diabetes, making sure that they're having a snack before they exercise, so that their blood sugar doesn't plummet when they're exercising. So all those things. At work, so we might go to the person's day place and see them there. There was a man that I worked with who was having a lot of issues with cellulitis. So that's an infection that people get from if they have like a cut on their skin, and he had edema, so he was retaining fluid, so his legs were really big, so it's stretching his skin, and the infections were getting in the cracks in his skin. The simple solution was just to put his feet up. So at work, he's putting his feet up. They have a plan for him to raise his legs for half an hour twice a day. He's doing it at home. And there's been very little cellulitis now. So, and cellulitis can end you up in the hospital with IV antibiotics. So, and that was a really simple fix. So, we also do a lot with end of life issues. So we could be the first ones to bring up whether it makes sense for this to be end of life for somebody or not. So you often find providers either recommending it too early, like the story with the guy in the hospital who was not near end of life, but the provider had made that assumption. Or you find that hospitals are very reluctant to say that this person could be end of life and continue on with the treatments or the exploratory, whatever they're doing to try and figure out what's going on. And I think most of the hospitals in Madison have actually been sued at one point or another for recommending hospice when it was inappropriate. And so they are very reluctant to actually go there now. So that makes it really, really hard. When you have a medical provider telling family that this person, or not mentioning hospice, or not mentioning the palliative care, and keeping on with, we can do this test and we can do that test, and you know the person is suffering. It can be really hard for families to then make that choice to say, okay, I think this is end of life. So we've had that situation too. Not in every hospital in every situation, but it has happened where they've done way too much testing for somebody, and they've been in hospital for 2 months, and really that was unnecessary, and it made it very hard for the guardian to decide that yes, we're not going to do any more treatments, and let's just do palliative care. We're often also the ones to bring up DNR, or do not resuscitates, for people, and that's a hard choice, I think, for families and guardians to understand and to make. So just explaining that do not resuscitate can just mean allow natural death, rather than, and it's not that they're going to withhold treatment. That's not what it means. It means that if this person's heart naturally stops, then you don't want it to be started by, by electric shocks, or by having your chest pounded on, which, leaves people with broken ribs and, all sorts of problems. So explaining that and giving families a clear understanding that they're not doing everything they can for the person. This is actually a natural way, and you can provide a lot of comfort cares for people. So we also advocate for hospice, like in-home hospice. So most of the folks that we support will die at home. If they're end of life, will die at home with hospice, or a lot of people actually go into the Grace Center, hospice center there, if their symptoms cannot be managed. So we work with families and teams to allow people to have a good death, right? To allow people to pass away in a way that is comfortable, and as comfortable as possible. Okay. Just want to say that we do work with people, a lot of people who have very complex needs. So whether that be that psychiatrically their dysregulation makes it very hard to support them We work with a lot of people who have 2-to-1 staffing because of their dysregulation. And our role in that situation is to figure out is there something physically going on that can cause the dysregulation in the person. Are they having pain? Are they having constipation issues? Are they having discomfort, allergies, headaches, whatever it is? Food issues, are they having GERD? So we do work with a lot of people who have a lot of psychiatric issues. We also work with people who have significant cerebral palsy. So they might be tube fed, so they have aspiration, they can't swallow because they have aspiration issues, and a lot of spasticity. So working with people, especially as they're aging, working with people to help them maintain as much range of motion as possible, be treated for pain, right? That often goes undetected. People often do not have their pain treated. So residential providers have to have it on their MAR, their medical record, that they can give something, right? So if it's not on their MAR, they can't give it. And I have been in teams, I have been with individuals who don't even have a pain, like a Tylenol on their MAR. So that means they never get Tylenol, which is crazy, right? We all need to have something for pain. So advocating, sometimes even doing a trial, if the person can't tell you verbally that they're having pain, doing a trial of pain medication for a week to see if it makes any difference. Yes?
Just a quick question, if that's okay. What would be symptoms that you would look for in somebody that's nonverbal, like a higher blood pressure, or are there like specific things that doctors look for?
It depends. It's usually behavioral, so you're actually being a detective to try and figure it out. There's no standard sign, but say somebody has not had a bowel movement for a few days and you can see that their behavior escalates on day 3, then okay, so that's probably correlated. They probably are having discomfort from that. If they have allergy symptoms, so their runny nose or their stuffy congested, you can make a good guess that they're having some headaches. And so doing a trial of whatever medication makes sense for that and seeing if it helps, right? So it's a lot of kind of trial and figuring out what correlates with what with people who don't communicate verbally. Yes. All right. I'm gonna talk a little bit about the common health problems that we do see for people. Dehydration, not drinking enough fluids is very common. People, and it's often not, the team doesn't necessarily pay attention to how much somebody is drinking throughout the day, and they're probably in the morning, they're at home, they may go out during the day somewhere else, they come home at night. How do we know how much that person is drinking? And that has all sorts of implications for health, especially for constipation. So we can set up a plan where we know that somebody is drinking, 2 glasses of fluids before they leave, and then they take a water bottle with them to work, and then they finish that water bottle, and then when they come home, then so that it's planful about how much a person is drinking. It can affect skin issues. It can affect all sorts of things. And then if a person isn't drinking, then figuring out why that is, right? Is there tooth pain? Is there something going on with their stomach? Again, constipation is such a huge issue for people, right? That we actually, the Wynn nurses teach a class on it. It's called Go With Your Gut, and we didn't want to call it the constipation class because nobody would come. But basically what we're talking about is healthy eating, healthy diet, exercise, fluids, and keeping people regular. So what happens, the reason that we teach, I think it was maybe one of the first classes that we started teaching. So again, we work with people who have been in institutions or people who have not and have been on medications that cause constipation. And what happens over time is that the bowel gets distended from the constipation, and then it never really gets its elasticity back again. So that means that it can twist, or it can pocket, or there's all sorts of things that happen to people when they've had chronic constipation. So we have lost too many people in the system. I mean, they've died from this issue. So that now it's kind of one of our top priorities because it's not a fun way, not fun to have a bowel impaction, and still lots of people get them, and then they're in the hospital with a nasogastric tube in their stomach, which is pumping stuff out of their stomach. And they're like that for days. They can't eat or drink, and it's miserable, and people can die from it. So, that is why we make it a huge deal. A lot of people, as they're aging, or if they have cerebral palsy, have swallowing issues. So making sure they're on a safe diet, so they don't aspirate and end up in the hospital with pneumonia. So one man that I work with, an older man, he was failing to thrive, so he was losing a lot of weight. And the staff people said he's just not interested in eating or drinking. He has aspiration issues, so his food has to be blended and his drinks have to be thickened, and he wasn't interested in that. So it's a great team, and they did a lot of different things for him, including just engaging him and making sure that the depression that he has wasn't impacting his wanting to eat too much. And also they have a protocol where he can actually, if they clean his mouth properly, he can drink water that's not thickened. And those two things have made a huge difference for him. He can now drink water, because if you aspirate water into your lungs and your mouth is clean, it's probably not going to cause a pneumonia. And so he can do that, and he does that 2 or 3 times a day, and it has made huge difference for him. He wants to eat. When he's drunk water, he wants to eat. So yes, that was an amazing, a great team to be a part of. So using adaptive feeding equipment so that people can be as independent as possible. And we do see a lot of people who have G-tubes. So as they age and they have aspiration issues, then the choice, whether that person can choose or the team and the guardian choose to do a G-tube or not. It's a very personal choice. And then that comes with a whole lot of other issues, you know, is can the person tolerate the feedings, and taking care of the wound, the stomas. So we will, and making sure that the person's sitting upright to get feedings, because they can still aspirate. So we're involved with that. Number of people we support have obesity issues, and then they can have the complications that come along with that, like diabetes and skin issues. So we can work with the person to try to make some healthier changes. So it might be that, you know, we work with the person and what they're currently doing. So where is that person at? What are they eating right now? And can we make some really small changes to help them make some small changes to their diet? Can we help them to exercise a little more and make sure that the skin issues and the diabetes is under control? So pain, like I said, pain goes untreated way too often, and we teach a class on pain as well, because it's such a huge topic. A lot of people who are aging have arthritis and they're not being treated. The number of times that, I don't know, I get a sinus headache and I'm taking something for it, you know, you wouldn't know if somebody is not communicating verbally. You wouldn't necessarily know that they have a headache. So again, being aware of it, you don't want to overtreat, obviously, with pain medications, but that's not the issue. People are really undertreated for pain. So making sure that people have appropriate pain relief after surgeries, after procedures, etc. So seizures, we work with quite a few people who have seizures, and making sure that the team understand and have a protocol in place about documenting, and they know how to position a person when they are having seizures. How can we prevent this person from having seizures? What are the triggers for this person? And then people are on medications for seizures, which have a lot of side effects. And paying attention to the medications that they're on, because some medications might work better for people than others. So they have Keppra is one that is a newer seizure medication that causes a lot of, so people will stop eating, stomach upset, and irritability. So if somebody is not nonverbal, that might manifest in their behavior, but you might not necessarily put those two things together. Oh yeah, the person started Keppra. So working with somebody who was put on Keppra, who was able to verbalize how it made them feel. And she said, I just get so mad. I get really mad. And she lost a lot of weight. And when she was taken off of it, those symptoms went away. So there's another medication, other medications that can cause symptoms that look like dementia. So somebody might, or gait issues, so somebody might have balance issues, and that could be the medication that they're on. So consulting with a neurologist is really, really important. Orthopedic concerns, a lot of people do have arthritis. A lot of people have osteoporosis as well. So anybody who's been on seizure medications for any length of time, they could be at higher risk for developing osteoporosis, which means that they're at higher risk for fractures. So making sure that is diagnosed, that people are having the right treatments. It's often overlooked in this population. So having a bone density scan is really important, especially if somebody has broken a bone. And genetic syndrome, so people with Down syndrome can have a lot of back issues or neck issues, instability, stenosis, arthritis. And so making sure, again, that that is treated. We have people who have UTIs a lot and trying to figure out, there's many reasons why people can get urinary tract infections. It's very common. So teaching staff about the fact that it can, when somebody is developing a UTI, it can look like it can be behavioral changes. The person can be less able to express themselves, or the first symptom can look like a behavioral change for UTI. So it's one of the first things that you want to rule out if somebody is having any changes. And trying to figure out what is causing the UTIs. And those can be some pretty simple fixes. As simple as maybe adding a cranberry supplement into their diet, or just the way that they shower, personal hygiene issues, and then incontinence and what is the reason and how to deal with that. A lot of people have GERD from either from medications or from whatever that would be. So making sure that that is treated, that they're on the right medication for that. And sometimes, so we see a lot of people, again, who have had constipation issues and end up with an ostomy. So if you see this is an ostomy site here. It's actually it looks like a healed ostomy site, but so that's what constipation can lead to, is that the person is no longer able to have bowel movements by themselves, and so they need to have an ostomy. And so that has a lot of issues that go with it as well. Dehydration can be a big issue for somebody with an ostomy. This skin breakdown around the site. So again, I talked a little bit about mental health and behavioral issues. So some of the antipsychotic medications have the side effects of potentially raising somebody's blood sugar or cholesterol. And so you want to make sure that that is being monitored. And maybe if the person has a family history of diabetes, then you might want to try and avoid certain of those medications, if you know that. But trying to control that would be a really important thing. Making sure that somebody is not on too many meds. Often meds get added, and then it's never thought about to actually take them off again. So is this med something that is still needed? Could it be reduced? Is there something better on the market now that might have fewer side effects? Mobility issues. So a lot of people have falls or as they age. So trying to minimize the falls, especially if somebody has osteoporosis, puts them at high risk for breaks. And so if somebody has been in the hospital, has maybe fractured a hip, goes into rehab. I just was working with a woman who has just gotten out of rehab. And she broke a hip and she fractured her hand as well, and she does have osteoporosis. So working with the team to make sure that transfers are done carefully, that, you know, she's going to physical therapy to try and regain some of that strength. That, you know, just basic things like people know how to transfer her properly, and that she has the right equipment at home. Spasticity, you know, if that goes without treatment, then people can develop contractures. So, you know, if somebody has cerebral palsy and they're not given adequate range of motion daily, then it can end up being often people's hands are tight, and so that can end up getting worse as time goes by, and then it's even harder to do the range of motion, and they end up with skin issues in there as well. We have a number of people who have diabetes, and that comes with a lot of complications. So it's probably one of the medications. So the insulin that treats diabetes is scary, because if you give too much, the person can die. And so it is trying to work with a team so it has a very clear protocol about how to give the insulin, but also working with the provider to see if there's any way to simplify it. Is it possible that rather than being on insulin, a person could just be on medications for that? So trying to simplify that for the team. And skin breakdown we see a lot as well, and those two kind of can go together. Diabetes, if you have diabetes, you can develop pressure ulcers, and that's difficult to heal. We also deal with a lot of people who do have, so if they have cerebral palsy, for example, or use a wheelchair, then they can have skin breakdown and develop pressure ulcers, and that can be really hard to treat. I'm working with one woman just now who has had very small pressure ulcer for about a year. And we've tried everything, from positioning to having home health come out 3 times a week. Now she is at Central Wisconsin Center with a wound vac. So it's a way to treat wounds that's pretty specialized, and it's finally working, but this is a year later. So that can be really tricky. So trying to teach teams about positioning and trying to prevent that skin breakdown is so important, something that we can do. Yes?
So who pays for all this if they don't have like insurance, if they don't have private insurance?
So MA, most people that we work with have Medicare, Medicaid, and they might have Medicare as well. So that pays for it. Everybody that we support who is in the system does.
All right, so they already have it.
Yeah.
Prior to, okay.
Yeah. So, but again, the focus would be on prevention, trying to prevent the skin breakdown and the pressure ulcers, because this person is also not being able to go to work for a year. So she is someone who has very, very significant cerebral palsy, and it's just been very, very hard to treat the wound. But usually we can do a lot to prevent that kind of thing from happening, and it's just working with the team to figure out what's going to work for this person, when can they recline in their wheelchair, what makes sense for that, positioning in bed at night. So the person wants to watch TV while in bed, and so they're sitting up in bed all night, and so they've got pressure ulcers on their buttocks. And so how can we change that situation? So we had the TV actually moved so that the person could lie down in bed at night and still see the television. And so, that's one of the kind of simpler things that can be done. But it takes a lot of communication and teamwork to figure out what exactly it is that's going on. And this is just classes that we teach. So Go With Your Gut is the one that I was talking about, that's about the constipation, about healthy eating and exercise. Living with diabetes, Is It Pain, and Save My Skin. So hopefully you've gotten a sense that those 4 issues are really huge issues that we deal with. We're also developing a class on end-of-life issues. So, yeah. Any questions? Yeah.
How do you actually get connected to any of these people? How do you know that someone is in the hospital? How do you know that they have an appointment that needs you to go to, and why you other than another WIN nurse?
Sorry? And
Why you rather than another WIN nurse?
okay.
How do
Yeah.
you connect with these
Yeah,
people?
so people have support brokers. You're familiar? They have case managers, social workers in the system, and they are aware of our service. So either they or residential would do a referral to us, and it's usually we discuss there's only 3 of us, and we discuss it as a team as to who would be best for this person, and then we would start working with them, and then you're in with all the communication with the team. And so, you do home visits, and you get to know the team, and you get to know the person, and you ask for what are the next doctor's appointments coming up. Sometimes we don't hear when people are in the hospital. Quite often we don't hear about appointments or when people are not in the hospital, but often we do as well. So it depends on communication. Yeah. Yes.
How many, this may be kind of a hard question, but like how many people is the WIN program serving right now?
We have about 300 people that have open files with us. That is growing. So we are getting busier. We have actually just had to start a wait list for our services. We were down a nurse for a while, and so we were getting referrals in, and we were covering for the other person. So we have had a wait list for a while. Now we're up and running with 3 nurses again, and we can start taking people off the wait list. But we've never had to do that before. Yeah. But obviously we would prioritize. So if somebody has an immediate, urgent need, they're not going to be put on a wait list. So it just depends. Yes.
This might be an odd question too, but thinking about like the medical community, doctors, nurses, other medical professionals, how do you think in your conversations or dialogue with those professionals, do you feel they're aware of disability issues in the community?
So it varies greatly from one provider to another. We tend to like the providers who are willing to listen. Not necessarily that they have the experience, but they're at least willing to listen to the team. So listen to the people who know them best. And we, over the years, you figure out who the ones are who are willing to listen, and they tend to get more people. They tend to have referrals for more people. We do have some doctors who have personal experience of IDD, and they tend to be pretty good and pretty understanding. So, but also, like I say, it's a willingness to learn, a willingness to be open and listen and learn, and that varies, obviously. Okay. Yes.
You didn't mention this in the presentation, but can you talk a little bit about like concerns of dental care for people?
Dental? Yes. So the Max Pole Clinic that was where a lot of people got their dental work done is closed now. And so that's left a real void in the system for where people can go to get their dental needs taken care of. And it continues to be a void. The access, community access, dental are taking people on, but they're overwhelmed with the amount of people. And they don't have the capacity to do sedation dentistry. So a lot of people that we support might need either completely, be anesthetized or sedation. And so it's a huge issue that people are working on right now. There's a committee that are working on it to figure out how that need is going to be addressed, because it's not being addressed just now. People are using their own contacts to get people into their own dentists. But there are people that I know who have not had exams for a couple of years because there's nobody to do it. And we don't know if they're having dental pain. So it's really it's a significant need. Or people are having to travel like a couple hours, I think. There are other, apart from being hospitalized to have anesthetic, there are other ways of sedating people now, like conscious sedation, that hasn't really been tried, or nitrous oxide, that hasn't really been tried as much. It was kind of assumed that people would be completely anesthetized and for their procedures. So I think there's a lot of trials that need to be done for people. How could they tolerate this procedure? How much sedation do they need? Right. Anything else? Oh, okay. Thank you.
Thank you.